Unshelling Medicine Podcast. Healthcare in the language we understand.
Hello, welcome everybody. We have an episode today addressing something that is insidious in nature, however, it does affect a lot of people and is often misdiagnosed. So I have the pleasure of having with me Dr. Blaskovich. Dr. Blaskovich is a Cranioscervical Junction specialist. It is a mouthful. That's why we have him here to, talk about it, explain it, and educate us. So if you have a young child who is active in sports, football, or an adult, or anybody who does anything that is physical, this would be a great episode to listen to and to educate yourself and also educate your loved ones. So Dr. Blaskovich, welcome. How are you?
Very good. Thanks for having me on. Appreciate it.
I'm very grateful you made time to be with us today. So let's talk about your specialty, the Cranioscervical Junction. What is that? Where is that? Why is this something that should even have a specialty?
Yeah, so it's not a designated specialty. I've kind of created this out of my own personal history and what was useful, what showed to be useful for me, and what has provided benefit in figuring out the origin of my persistent symptoms. And also it's obviously trickled over into being able to assist lots of patients who are dealing with this, who are not getting answers elsewhere, to get some direction in their lives and hopefully some improvements in their symptoms and their daily function. Basically, when I sustained my injury playing football roughly 30 years ago, it was diagnosed as a concussion and it was treated as a concussion. It was classified as a concussion, but the symptoms did not get better, and if anything, started progressing. And then luckily, I was blessed to have already been going in the direction of becoming a chiropractor. And so after my injury, I went into chiropractic school about 2 years after that and started progressively getting worse and worse symptoms of headaches and blurry vision and fullness in my ears and just the whole gamut of what people would classify as post-concussive-like symptoms. And they were persistent. And luckily, going into chiropractic, because the profession is very biomechanically oriented, so we really focused on the position and the function of bones as they relate to the nervous system. It gave me the ability to look in a direction that I think mainstream medicine is not taught to look in. And so from a biomechanical standpoint, so how pieces work in conjunction with each other, it allowed me the ability to know where to look to try to figure out what my problem was, because I figured for the longest time it was not in my head. And if whatever I was feeling in my head was originating somewhere else. And so ultimately, what that did was lead me down a path that I eventually figured out that the upper neck, so the first and second neck bones, which we term basically the cranioscervical junction, and this just simply means cranium is head and cervical is the neck. And then where they meet, we call it a junction. And so that encompasses the base of the head, and then the top two neck bones is really what the cranioscervical junction is. And it turns out that my injury resulted in not having my brain slosh around in my skull and beat up against the front and the back of it like we're taught that concussions occur. That did occur. But the true problem that arose with my injury was that trauma caused ligaments in my upper neck to be stretched or torn. And anybody who's known anybody who's ever had a knee injury, so where they say they've blown out their knee, that means that they've stretched or damaged or torn ligaments, which then from that moment forward render their knee to have too much mobility or too much movement, which predisposes it to re-injury and worse injury. And so ligaments by default in our bodies do not heal. And by that, I mean they do not recoil back to whatever their original length was and then scar up or patch up. So any what we would call healing that occurs in ligaments, because they're non-elastic tissues, so they're like ropes basically compared to elastics. So they're a fixed length and they allow for bones to come closer together, and then the ligaments will buckle. And then when the bones are pushed apart, the ligament becomes tight. So if you have a rip in that, now that endpoint either never occurs because it's completely ripped or occurs later. And so that means that the joints then move too much in relation to each other, which, for example, in the knee can only lead to premature arthritis because you're grinding away the bone in between or the cartilage in between. And that's not good to have. But when you look at the spine, anytime you have excessive movement in the spine after an injury, that spine, its number one job is to protect what's going all the way down through the 26 bones, and that's the spinal cord and nervous system. So now all of a sudden, when you have these 26 stacked bones that are supposed to protect this important electrical system that's going through there, now being the actual things that are irritating that nervous system because they're moving too much and they're nudging up against the nervous system, you start having neurological manifestations. And so, as it turns out, in the upper necks of people, so the cranioscervical junction, when you have injury to the ligaments there, because the bones end up moving too much relative to each other, those bones now start irritating the brainstem and spinal cord, causing a gamut of neurological symptoms that present as concussion-like.
Yeah.
And so when you have that and the diagnosis is missed and everybody's focusing on the brain and brain healing and brain recovery, and they're not really getting anywhere, the number one place that I would suggest to go have inspected or get checked is the upper part of the neck to see if there's anything going on there. And what makes, I guess, my version of cranioscervical junction specialty unique is that I don't specifically focus on the position of the top bone at any given time. What I focus on is the proper coordination of the neuromuscular system, which then can properly coordinate the position of the top bone at any given time as it senses it going off position. And so when it's off position, it's simple enough to say, okay, well, let's, as a chiropractor, let's adjust it back into position and restore that, openness of those channels. But if you have torn ligaments, that could go out of position in a heartbeat. And so the only thing that can coordinate that is ensuring that the nerves and the muscles are properly sensing that that's going out of position and recalibrating constantly. And when they lose the ability to do that, which it happens when they've been overworked, they go into a lockdown state, which then causes a malposition to the other side, which then again puts pressure on the nervous system, resulting in symptoms. And so the main technique that I would employ on myself, but also patients that have this, is simply what's called ischemic compression, or squeezing all the juice out of the muscles that are needing to be reset, so that when you then release that, fresh blood rushes in with nutrients and oxygen, actually replenishes that muscle and resets the circuits where the muscle can now sense that bone going out of position and recalibrate it continuously until it locks down again. And then you can repeat that perpetually. And so I've been repeating that perpetually on my own neck for the last 24 years since I figured this out. And it's been very effective for the most part.
Wow. That's incredible. And, when we talk about concussion, the one thing that we focus on most times, because it's commonly resulting from playing football or other contact sports, is that accidents also, motor vehicle accidents also can cause this. And most times when that shift actually does happen in that cranioscervical junction, right, it is a very sensitive spot, right? Because any wrong intervention can lead to paralysis, right? Modern medicine, the focus is, to go in and surgically adjust it. And it carries a 50% of, paralysis or effectiveness. So if somebody has gone through the gamut of testing and it has been identified that there's a shift in this vertebrae, right? And in this bone that is connecting the neck or the head to the, to the spine, or to the neck, I should say, not,
Yep.
I'm getting technical. I don't want to, if there's a shift in that bone and there is a concern of paralysis, because this is what has been the feedback so far, what can that person do? Somebody listening to you today, or knowing somebody who has this unfortunate occurrence?
Yeah, sure. Luckily and thankfully, paralysis is extremely rare. And that's usually when somebody is at risk for paralysis, their neurological symptoms are extremely severe. And oftentimes the actual problem is found by the medical community, but sometimes not, unfortunately. But the most important thing to have done and utilize for diagnostics, and when you say, people have had the gamut of testing done, there is the gamut of testing, and then there's extra stuff that most medical practitioners don't know even exists that is much more effective in diagnosing this. And the number one modality for this that is available and non-invasive and effective, most effective in seeing this pathology, is motion X-ray. So our clinic here in Langley, BC, Canada, and our clinic in Linden, Washington, in the States, we have a motion X-ray machine in both of the clinics. And the sole intent of that device, or that X-ray machine, is to test people who are suspected to have these injuries in real-time motion. So we do the x-ray while the patient is performing certain movements with their head and neck so that we can track in real time how much the bones are moving in relation to each other. Okay. And we can make measurements, and due to those measurements, we can predict and determine how severely impaired that injury could make them. And then based off of knowing that and seeing that excessive movement in real time and not inferring or guessing that they possibly have it based off of their symptoms, we know exactly where to start as far as trying to treat the patients. And so, like I said, the neuromuscular treatment that I do is the least invasive, easiest to implement, and also the easiest to teach a person to self-administer, which in my case, I think is the most important message I can get across, is that what I do on my patients as far as treating them from this neuromuscular standpoint is something that any patient can learn to do on themselves. The only clincher or the only problem with that is that oftentimes that self-treatment is oftentimes required many times every day to hit that reset button perpetually, like I was saying at the beginning. And so not everybody can wrap their brain around having to do that or wanting to do that. So then the people that either can't or won't or don't want to do that kind of stuff, there are regenerative medicine techniques where this becomes invasive now, where they can inject certain compounds into the ligament areas where, again, with the motion x-ray is the gold standard for them to be able to know, okay, this is exactly where I need to inject these compounds to try to stimulate ligament regrowth or ligament healing, if you will. And so no matter how you slice it, the motion x-ray is the gold standard for determining where to treat and how best to treat, depending on that patient's requirements, desires, wishes, and how much they are willing to basically work on themselves, or how much they want to put into somebody else's hands to attempt to try to, generate some healing at best possible. And so this motion x-ray is by far the gold standard. And then second to that would be, the conventional imaging, which would be regular x-ray and or MRI or CT, where a patient is put into stress positions. So for example, normal imaging is done with the person in anatomic neutral position. And then the imaging is done, and if nothing is dislocated or fractured or severely arthritic, generally the x-ray report or the imaging report comes back and says that it's unremarkable, so they didn't really see anything. And that's simply because they're looking for a massively visible pathology. And so when you do these stress positions, you take someone out of the neutral and you would put them in a position of rotation and then conduct the imaging with them in a stress position. But unfortunately, that has not yet become a standard anywhere. It's really very difficult actually to get x-ray and MRI and CT facilities to do this. They require, a lot of special instruction to do that. And then moreover, you have to hope that they have a radiologist in their system that knows how to evaluate these non-standard MRIs or CTs or x-rays and then report on them effectively so that the referring physician gets a note back with some information that is useful, as opposed to just the usual, we see everything looks unremarkable, or normal degenerative findings for this person's age, right, which doesn't really help anybody.
Yeah, super vague. So when we're talking about the healing process or the treatment process, from the way you're explaining it sounds like a lifelong intervention as opposed to a periodic intervention and, maybe an expectation of treatment for 6 months and then you're well off on your way. So am I understanding that correctly, that this is a lifelong process?
Yeah, you are, because ligaments, so far, and if anybody's watching this who's in the medical field has anything that shows this, but I've looked through literature for years now and trying to find evidence that ligaments on their own can heal. I haven't found anything like that. And so if anybody listening to this has that, search me out, whiplashclinic.com, or, just Google my name, Sasha Blaskovich, and share that with me, because I'm very interested in that. But like I said, I've been searching for that for decades now, and I've never found any literature that conclusively says that when you take a 10 centimeter, and the knee ligament is the most studied, so the ACL, when you take let's just roughly say it's a 10 centimeter ACL, and when you have an injury to the knee, it becomes 11 centimeters. So there's 1 centimeter of lengthening of that ligament. I haven't found any literature that says that there's a way to make that ACL shrink down by 1 centimeter and then heal or scar or patch up. Any healing that happens at 11 centimeters. And so now you have 1 centimeter of extra movement in that knee for perpetuity. And so that person will constantly have to either keep their leg muscles strong by exercising them, will have to wear a knee brace so that 1 centimeter of extra play while they're being active doesn't, grind up their cartilage in a particular movement, causing them to have repeated re-injuries. Or they'll have to have surgical reconstruction of their knee to basically shorten that ligament down so that they have proper integrity of the knee movements. And so if like I said, if anybody knows of any literature that actually states that these things can, in whatever way, recoil back down to a normal length and then heal, I'd love to see that, because so far what I've experienced in myself and thousands of patients from around the world over the last 25 years is that there's no evidence of that clinically. And as soon as you do damage to ligaments, it is a permanent injury, and that's why we call it that, because it does not restore itself no matter what you do. And there are, like I said, some tools that can be helpful, such as the regenerative injection therapies, which have proven to reduce some of the excess movement that we see on the motion x-ray. So we can do a motion x-ray before, do the therapy. If a person can't wrap their brain around the neuromuscular therapy, they will go for these regenerative injections. And then we have tested some of the patients again on motion x-ray, and they have had a reduction in how much movement we see in the bones, which is great. And they also feel better. But the pure restoration totally to zero movement, or zero pathologic movement, I should say, I haven't seen yet. But even a slight reduction in the movement and stabilization of that has neurologically benefited these patients greatly. And then the last endpoint of that, if the regenerative injections don't pose enough benefit for the patient, then the last resort is surgical fusion of those two bones where they're completely immobilized. And generally the people that undergo that are having really severe neurological manifestations, like they're blacking out, they're losing bowel and bladder control, and pooing and peeing themselves, and they're just completely unable to be upright. And so those people would be then more classified as surgical patients, and I've seen those patients completely regain their life after undergoing that. But again, it all ties back to being able to visually see that they have this severe instability, and the motion x-ray is the gold standard for that.
So, Dr. Blaskovich, why do you think ligaments do not have, especially you mentioned that the one that is most studied is the knee, right? And we have major junctions, bone-to-bone junctions in our body. Ligaments connect bones to bone. They're that, rope, like you put it, that kind of like controls the motion or helps support the motion of a joint. Why is it that we don't have, because the more and more I talk to people in the healthcare community, the more and more I discover that we don't nearly know all about the human body the way that we really should. And we deal with human body every day. And yes, we are growing in knowledge and, discoveries and understanding what is going on, the beauty that is the human body. Why has there been so much focus on the ligaments in the knee as opposed to the, shoulders, as opposed to even the hip or the cranioscervical junction? I mean, the medulla is right there, and we're dealing with a spinal cord. That is as sensitive could get. So why has the emphasis been on the knee?
Well, first of all, there is research being done, and there has been research being done on the cranioscervical junction ligaments and shoulder ligaments and hip ligaments. It's just that by sheer numbers, the amount of research that has been done on the ACL far outweighs the amount of research done on any other ligaments. And it's simply because it's easily accessible, it's massive, and it's easy to see, and you can test it more easily, whereas the integrity and the sort of hidden nature of the spinal ligaments, and there are lots of them, makes it such that they're harder to study. They're not impossible to study, and they are being studied. But the ACL is by far the easiest in the body to access and study, especially because a lot of the cranioscervical ligaments are actually internal. So they're intraspinal. And so you can't really readily access them on a living human being. So it's got to be done on cadavers.
So is the ACL also the most injured?
That I don't know the stats on that, but probably it's up there because it's quite easy to injure. I mean, it doesn't take much to injure it, and it's quite amazing that some athletes can get through an entire career without having injured it. But yeah, it's most susceptible in any kind of a sport where it involves cutting and changing directions and contact. When you add those two things together, it's very susceptible to injury.
Right. Okay. So let's talk about symptoms that you would absolutely not want anybody listening to you speak today ignore. Some symptoms can be very insidious, where people do not, think it is one thing and it's absolutely a red flag. So what can somebody really pay attention, or what should people pay attention to, especially if they've had a history of any form of injury to their neck or head?
There's a whole list of them. The most common ones I would say people present with are headaches, pain at the base of their skull, just below their skull in the upper neck, blurry vision, double vision, ringing in their ears, fullness in their ears, heart palpitations, so their heart racing, difficulty breathing, exertional malaise, so when they exercise, they're much more fatigued than they should be, bowel and bladder changes, so diarrhea, constipation, increased urgency to go pee even though they haven't drank a lot of water, stomach acid reflux, balance and coordination issues, coordinating thoughts, so short-term memory. Those are some of the main ones. And then like I was saying, you can have the more severe version where they're actually literally blacking out and then losing bowel and bladder control. And those are technically emergency situations for a referral right to the ER.
So for our colleagues in the medical, space or healthcare space, if a person presents with these symptoms and there's a history of this diagnosis, at what point do you stop experimenting and collaborating with, say, specialists like yourself and your clinic? Because the advancement that you mentioned with the motion imaging test is not available in every healthcare facility, right? It's not available in every healthcare system.
Correct.
So what will the messaging to colleagues be who are either directly treating these patients or they have a patient in connection with another doctor, say a primary care doctor who has a patient seeing a neurologist because of brain or cranial injury?
I think when you have a trauma and you have the origination or the manifestation of these neurological symptoms that I just mentioned, and they could end up getting diagnosed with POTS, dysautonomia, myalgic encephalomyelitis, chronic fatigue syndrome. Like there's a whole cluster of named diagnoses that don't really tell you what the problem is. They just explain that there's a particular cluster of symptoms like POTS, for example, so postural orthostatic tachycardia syndrome, which just tells you that when the person changes position from sitting to standing or lying to sitting or lying to standing, that their heart races. Yeah. And that's great because you're basically describing their symptoms, but it's not telling you the origin. And so when any physicians or therapists or clinicians have patients that manifest these neurological symptoms, or a number of them, not necessarily all of them, but any number of those symptoms that are persistent, and even occasionally they will say that they get worse after vestibular type treatment or after a traction type treatment or even after a manipulation type treatment or even a strengthening treatment like the deep neck flexor exercises that are being perpetuated. If a person has upper cervical instability, those general treatments that we would utilize for the neck actually are more exacerbational. So they actually flare people's symptoms up as opposed to reductional. So people generally don't feel better after those types of treatments. Everything thankfully balances back out again. But if they repeatedly get exacerbated and flared up by those standard treatments that are implemented for vestibular-like symptoms or, cervical pain and headache-type symptoms, then the assumption can be made by those clinicians that they're possibly dealing with a patient who has severed ligaments in their upper neck. And then a prompt referral to someone like myself who has a motion x-ray should be made no matter how far the distance is, because once you have that imaging and the results of that imaging, the tailoring of a proper treatment plan is significantly more effective and significantly more directed towards addressing the fact that your patient actually has instability as opposed to a restriction in movement.
Yeah.
Because the assumption is made, or the thought is there for, and I had this as well in the beginning part of my career, because whatever profession you're in that's hands-on mechanical or manual, such as chiropractic, physiotherapy, massage, osteopathy, the gist of all of our education is that joints are restricted in motion and they need to be increased or improved in motion. And there's very little focus put in our educational protocols that what we see, feel, and what the patient tells us presents as a restricted joint that's restricted in motion is truly a joint restriction versus a neuromuscular clamping down presenting as a joint restriction. But actually the reason that those neuromuscular systems are clamping down is because the true problem is actually hypermobility or instability. And so presents as a restriction in joint motion. So it would be treated as a restricted joint. So everything is focused on improving or restoring joint mobility. But unfortunately, the true problem with that joint is that it actually already is too mobile because of these injuries. So anything that you throw at it to try to improve joint mobility will irritate either the medulla or the cranioscervical or cervicomedullary junction of the spinal cord, resulting in a neurological flare-up repeatedly. And so when you see that as a clinician, you should refer out for a motion x-ray because, and again, no matter how far that would be, because the patients will absolutely respect and honor that referral once they have the information and they're now on a path that makes sense based off of their actual problem.
Beautifully said. So let's talk about the referral process. In the United States of America, we do have this cute little thing called insurance.
Right.
Right. Health insurance does not usually cover a lot of services
That are non-routine.
Yeah, if you're not within the network or may not be within the covered parameter per diagnosis, right? So when a provider and a patient are facing that obstacle where a provider actually wants to make the referral because they do understand that this is going to help them get a definitive diagnosis, a definitive treatment plan, and, a tailored treatment for this patient. However, that becomes an obstacle. Is your clinic insurance-based, private pay, or a little bit of both?
Well, we are in network with insurance companies, but they don't see this examination, this imaging examination as a routine, let's call it a chiropractic x-ray. Okay. And so they generally do not cover it. So most, if not all patients would have to then pay out of pocket for it. That's unfortunate. The fortunate component of this is that the vast majority, the highest percentage of patients who would need this modality are in a medical legal position where they've been in an automobile accident. And most of the times they're not the at-fault party, which means somebody rear-ended them usually. Right. And so the person who rear-ended them is at fault. And whether the patient that was on the receiving end, so the injured patient has their own insurance on their automobile policy called personal injury protection, so PIP. Some states have it, some states don't have it. But no matter how you slice it, if they're in a state that, for example, does not have it, then they usually will end up having an attorney that represents them for the whole process. And so that is something that can be conducted on what's called a lien basis. So basically, we would perform the imaging so that the information can be put into use therapeutically right away. And then either the attorney would then pay that invoice for the examination and then hold that to the end, and then they would recover that at the end upon settlement. Or we occasionally, depending on the situation, can actually perform the procedure and then hold that bill so long as the attorney and the patient can guarantee that once they have their settlement, because they shouldn't be technically, if they're in that situation, paying for it out of pocket because it's not their fault. So we occasionally can hold that until their settlement occurs, so long as the patient and their attorney will guarantee that they will fund that upon settlement. And then when you have, patients who have the personal injury protection and the referral is made by their physician that this is an indicated, necessary, and reasonable thing for the person to do to aid their recovery, then the personal injury protection will actually fund that upfront. They will pay for that upfront. And then when you're in a situation where those two things you don't qualify for those two things, then it does unfortunately become a thing that can be hindersome, but the patient would then have to pay out of pocket. And then they could submit that invoice or that receipt to their, whatever their insurance is, for as an out-of-network sort of specialty imaging modality, and then hope for the best. And what we've seen as well is that a lot of patients across the country have deductibles, right? So they have an insurance, but they also have a deductible that they have to meet. And until they meet that deductible, their medical expenses technically are out of their own pocket.
So is there a tiered system depending on the gravity of the injury, or is there a flat fee system?
Well, yeah, the imaging, basically, we do the imaging. We have to calibrate for measuring. So we manually calibrate each patient separately. So there's not a software that I believe does it effectively and accurately. So I will literally attach a ruler to the patient's neck for 2 of the 3 imaging sequences. And then when it's done, we have to then calibrate that measurement within the software that we then use to accurately measure. And then we, annotate the videos and pull out the actual frames that are showing the injuries with measurements. And then those images then get spliced into the actual report. So the reports that we generate on this are generally anywhere from 10 to 18 pages, depending on the severity and the findings of all the different ligaments that we find that are injured. And then we provide some instructions and recommendations in there for some stress MRIs, should the doctors then, in addition to seeing the ligament injuries on the motion x-ray, want to see, those ligaments on MRI as well. We provide instruction for that. And then, their treating physicians will get copies of those reports, and they can always have also copies of the videos, the raw videos themselves, to actually see in real time, so that as they're treating, they have a better visual of the internal of that patient, so they can make better, treatment protocols for that particular patient. And then, people do have way better outcomes when you have this, pertinent information on hand while you're doing your therapy. So the time involvement, so just to answer your question, the time involvement and everything that has to be done is no different for the tiered severity, because if somebody has severity enough to qualify for this imaging, it's severe. So whether you're talking about, 70% severe or 80% severe or 76% severe is severe. And so the amount of time and effort and dedication that it takes to conduct one of these from beginning of the imaging to the end of the report, and then the after report, and what would that be? Correspondence. We're always then open to, continued correspondence after that indefinitely. And so there's no additional charge for that unless it gets completely out of hand, where there's, we're having to write, opinion reports or anything sort of med legal, where it requires a lot of dedication of piecing things together to then put on paper. But just back and forth, the odd question, I just keep doing that in perpetuity.
Got it. All right. So when it comes to treatment, since this is your area of expertise, if a patient, yes, they come to you, the imaging is done, the report is sent to the doctor, and your recommendation are upheld. The doctor absolutely loves your recommendation. So does the person who came to get the imaging done. However, there's no specialist in their area to continue this treatment. Is that something that you can do? Yes, some aspect of the treatment, like you mentioned earlier, requires physical intervention, right? And the other aspect of the treatment that would require this person to do it on their own. Should they choose to continue treatment with you, given that, this is your area of expertise? What does that look like for a person that, one, may be covered by insurance, and two, may not be covered by insurance, or may have a PIP?
Generally, if they're coming from a further away distance, which happens a lot, I've taken the initiative to put on my YouTube channel several videos giving instructions to patients how to self-treat, either with their hands or with a particular device that I invented that is like an S-shaped plastic trigger point machine device.
Yeah.
And I've also put a video on there for, LMT, so massage therapists or chiros or osteopaths or anybody who's hands-on, an instructional video that's about 10 minutes long, showing them how to properly position somebody who has upper cervical ligament damage, and then how to perform this, let's call it acupressure, or this ischemic compression on a certain group of muscles that are always responsible for trying to coordinate instability when a person's had these injuries. So those are on my YouTube channel, and a lot of the stuff on my YouTube channel somehow pertains to this craniocervical junction pathology. Let's call it atlantoaxial instability or craniocervical instability. And so the YouTube channel is found under DRBs, so DRBS, so Dr. B's injury resources. And so if someone looks up Dr. B's injury resources, clicks on my face, they'll get into their shorts, videos. And so if the stuff on there is not for comic relief, because you got to try to keep life a little bit light. And so there are some videos of people doing silly, stupid things and injuring themselves that are for comic relief. But anything else that's on there is serious in nature and somehow relates to either gaining a better understanding on this craniocervical pathology or treating this craniocervical pathology.
Yeah. So how long between injuries do you recommend? Because again, unfortunately, people go months and years on end, trying to figure out what this is, like you mentioned with POTS. It's kind of like, okay, this is the presenting symptoms. We are going to treat everything that relates to that symptom, right? We don't want elevated blood pressure, heart rate, and stuff like that. So let's throw all this cardiac medication at it, as opposed to what is causing, this to happen. So in a case where somebody has either endured months or years of, basically addressing or treating the symptoms, and other symptoms are popping up, other symptoms are not resolved. Is that too late to seek out treatment with you, or
Never too late. No, it's never too late. And I
Okay.
think a really good take-home message to any clinicians and physicians treating these types of patients,
Yeah.
if they themselves have diagnosed somebody with POTS, or the person has come there and said, I've been diagnosed with POTS. So that's one component. So tachycardia, right? So heart rate variability. If the patient also says, well, I've got headaches, I've got blurry vision, my ears are full or they're ringing occasionally, I suffer from diarrhea and constipation. And if they haven't said that, the clinician should be asking these questions. Or I have balance and coordination issues, I'm really forgetful, I have stomach acid reflux, I have to pee a lot and I'm not really, hydrated. As soon as the clinician starts hearing all these different systems, or I have difficulty breathing, so you're talking about cardiovascular, respiratory, digestive, balance and coordination. So now you're talking about 4 different systems that they're telling you that are glitching. So, when you talk about people getting heart medication for tachycardia, if that's the only thing they're talking about, I guess that can make sense to me why a physician or clinician would say, okay, you need some, beta blockers or some whatever you need. But when the person is saying that they have 3 or 4 or even 2 different systems that look to be glitching at the same time, the clinician should go, is it logical that, the cardiovascular, the respiratory, the digestive system are all glitching at the same time, that there's an actual problem with that system that I would then either medicate separately with those systems, or if I feed that back into a more central perspective, is there something more central that links to all those different systems that, if irritated or compressed or somehow inappropriately stimulated, could cause those 3 different systems to malfunction and misfire at the same time, or roughly at the same time? The answer to that is yes. And the answer to that is basically the medulla, right? The vagus nerve, the wandering nerve that goes to all those different systems. So if all those different systems, or even a couple of those different systems, are glitching, it's not logical to put somebody on heart medication, because the likelihood that it is actually the heart that is doing something wrong is very low, but that the heart is doing something that it is exactly being told to do by an electrical stimulus is really high. Because I've even had, patients that have had several open heart surgeries, because when they evaluated their heart, oh, you have a patent foramen ovale, you have an actual birth defect that now at the age of, 42 is starting to bother you.
Yeah.
Possible. But they've had, several open heart surgeries where they've fixed these birth anomalies, but yet the person still has tachycardia and heart rate variability and blood pressure issues. So that means that it wasn't the actual heart causing this. It was something stimulating the heart, and still continues to do so, which tends to be the vagus nerve.
Yeah. The vagus nerve is so insidious and so beautiful at the same time. It controls everything from the mouth all the way to the rectum. So yeah, it's something that it's so amazing.
I mean, it's absolutely the most important nerve in the body, in my opinion. I even wrote a book on it last year.
Oh, wow.
So that explains sort of what the vagus nerve's role is in a sort of layman standard, and then also how you can reset vagal tone on a repeated basis daily to regain some of your life back on a repeated basis. So again, it's an ongoing battle that we have with this problem.
Yeah. Where can we find your book, Dr. B?
On Amazon. I think if you just go on Amazon and you just type in Sasha Blaskovich, you'll find both my concussion breakthrough book, which was the first one I wrote in 2019 with my co-author and patient, and then the vagus nerve, which was published just last year.
Oof.
And there's one more coming up pretty quickly here, and that's more for clinicians.
Okay.
On the investigations or the examinations that they would do clinically on patients, either hands-on, so active and passive orthopedic testing, and then the imaging protocols to use to better diagnose people with atlantoaxial instability or cranioscervical junction pathology.
Nice.
So that's going to be published hopefully before the end of this month.
Nice. So Dr. Blaskovich, let's talk about collaboration. How important is it for modern medicine practitioners to collaborate with integrative medicine practitioners for a better treatment plan for the patient, for a better outcome for the patient?
It's always been an important thing, not recently, but always. And unfortunately, I think in healthcare and in sick care, return customers are kind of what drives the system. And it's not the correct mentality to have. But I understand where it comes from, having gone through the education, had, student loan debt and all this other stuff. But at the end of the day, if you really listen to some of the respectable people in society that have, let's say made it or that we would consider successful, they've done it from a completely different paradigm than would seem logical and what most people are doing. So hoarding patients and not collaborating is probably the worst thing that you can do, because A, it's not gratifying and fulfilling, and B, it's not helping them. And so they're going to eventually, shop somewhere else. But if you know that there's somebody that you can collaborate with that has a particular knowledge base that you don't have, but is relevant for the patient's case, collaborating sooner rather than later is much more beneficial and much more gratifying for yourself as a clinician, and also more beneficial for the patient, obviously, than waiting longer and trying more stuff out just because you have the ability to try stuff out, or you have, wonderful gadgets in your clinic that are billable if you continue to keep trying them. But that said, I think collaboration is always the key. And what's interesting, that whenever I've collaborated with somebody who I think is, way up there in knowledge and in experience and in reputation, they've always been very welcoming and very amazing to collaborate with, because they've reached that point because of their true desire to help people and become icons in the sense of altruism. And so the reverse of, I think, what society is teaching people, selfishness, hoarding, and me, if you can reverse that and give it enough time, it'll come back 1,000-fold compared to trying to continually beat the path of selfishness and greed and me. But it's a hard paradigm to break, because everything in society teaches us it's all about you. You got to, fulfill yourself and make more money or whatever else, thinking that, that is the number one goal. But really the number one goal should be collaboration and doing whatever it takes that's best for that patient. And even if that means seeing them once and referring to somebody else who's going to see them 35 times, but they're better suited to do that. That one time that you see that patient and you've made that referral, they'll probably send you 4 people in exchange for that.
Absolutely.
And it does happen.
Yeah, it does. It does. It's the customer experience, word of mouth referral, that
100%,
trust,
yeah.
that trust. So, Dr. Blaskovich, what is, I usually ask my guests at the end of a conversation for either a golden nugget or a few golden nuggets for our listeners. So you've given us a lot of useful information for everybody that is willing to listen. And thank you for that. What is the one thing that, or a few things that you would want our listeners, both on the practitioner end and the healthcare recipient end, to take from this conversation?
There are tons of nuggets. The importance of the cranioscervical junction in these concussive-like symptom patterns is essential. And I guess the only thing that I can say is the information is there. It's freely uploaded for someone to watch and repeatedly watch and search through the titles and see what fits their particular situation possibly, is to just go to my YouTube channel and just scroll through the videos, read the titles, and see what seems interesting and potentially correlates to your own problem, and watch it and rewatch it and rewatch it. For example, I did a podcast, I think 2 years ago, with a gentleman who did a multiple sclerosis documentary some time ago about how this cranioscervical junction pathology could potentially be linked to eventually getting the diagnosis of MS. And so I can't even start listing all the nuggets that are potentially out there for people to gain some benefit from. But like I said, if you just go to the YouTube channel, DRB's, so Dr. B's Injury Resources, and just scroll through all the videos and see there's lots of podcasts, there's lots of useful information there, and it's free. Just watch it, rewatch it, learn from it. And if there's any questions, people can always get a hold of me. You just either Google my name or go to whiplashclinic.com or drblaskovich.com and just fill out the contact form. And I'm always engaging in responding to people. So
Absolutely. Thank you for that. And for everybody listening, we are going to make the show notes all about Dr. Blaskovich. His YouTube will be there, his website, the clinic, everything will be listed, because we don't want you to try to guess or try to remember everything that was said. We want it to be readily available to you. So if you're interested in reaching out to him, you will find that access, very easily, because we can all learn, we can all improve ourselves, we can all improve our practices. And for anybody in the healthcare industry or in the healthcare arena who really cares about making an impact, collaboration is key. There's so much that is left out of our individual education, because when you go into your specialty is very hyper-focused on you learning certain aspects, so you're not going to learn the other things. Trust the other people who learn the other things to support you in caring for your patient. The satisfaction is going to blow you out of the water, whatever water you're in. So, Dr. Blaskovich, thank you for being here. This was such a great interview, and I'm very grateful you made time.
My pleasure. Thank you for having me.
Thank you, sir. Have a great day. Thank you, everybody. Take care of yourself. Bye-bye.
Thanks for tuning in to Unshelling Medicine Podcast. If you want to stay up to date with the latest episodes, make sure to hit that subscribe button on your favorite podcast platform. If you enjoyed today's episode, please take a moment to leave us a review. Follow us on social media at Altruistic Scribe on Instagram, TikTok, Facebook, YouTube, and LinkedIn. We share additional tips, updates, and health-related content that you won't want to miss. Have any questions or topics you'd like us to cover in future episodes? Reach out to us at altruisticscribeco.com. We're always eager to hear from our listeners and tackle the health topics that matter most to you. Until next time, stay healthy and take care.